AOD and you guys are getting used to different charting and stuff, we're just going to do kind of a review and answer any questions you may be. This will be short, 20 minutes. So activities of daily living, right? Why do we have to code ADLs? Why does it matter? What's the importance of coding it? Yeah, she said it. Money, that's right. We want to get reimbursed for the amount of care that we provide. But take money aside of it. Can you find any other reason why we would want to code ADLs and show how the patient is doing?
Efficiency.
Yes, efficiency, and it can help with your staff patterns and staffing. Yes, that's right. And what about like progress and declines? Like if they are doing good and say therapy and nursing rehab, they're rehabbing them, you know, their ADL score should improve. And if they're declining, they have more medical complexities or whatever, their ADLs will decrease. And so a lot of government agencies like the RACs and the MACs and WPS and all those HP and all those people, they like to come in and they want to look at the ADL coding to make sure that it's as consistent as possible throughout all the disciplines. Now we know that the different shifts are going to be different. You know, you're going to have different ADL codes, but in general, you shouldn't see a huge discrepancy between therapy and nursing and the physician and so forth. So this is for the RUG levels using RUGs 4. So I'm talking about Medicare Part A skilled patients, okay? So there's 3 ADL levels, an A, B, or a C, okay? So say somebody comes in from the hospital, they have up to 100 days of skilled nursing care. They're here for rehabilitation and skilled nursing because they just had they had pneumonia. And so they come in, and if they, from what the CNAs put into the system, when you code your ADLs, at the end of the assessment reference date, have I lost you guys? You know how like they have those 7 days of assessment reference dates? That's because the government and the MDS, they want to see what you're doing for the resident every 5 day, 14 day, 30 day, 60 day, 90 day, if it's a skilled patient, okay? So it's like a snapshot of how this patient is performing. So by you guys documenting your ADLs, it in turn is going to give the RUG level or the reimbursement rate an A, B, or a C, okay? So A means that this patient is pretty independent. So medical reviewers will look at if they have a 5 day and they're at an RU, which RU means rehab ultra high. That means like almost all 3 therapies are working with this patient and they're getting 720 minutes, lots of therapy, okay? But then medical reviewers will say, well, why are they independent? They're not, I shouldn't say independent, but they're very high level. They're almost independent, okay? So medical reviews are really going to hit hard and say, why is therapy doing so much for this person when they're almost independent, okay? An RUB is moderate assist, so that means they need about 50% assistance with their ADLs and things. And an RU, say rehab ultra high with a C, means that they're pretty much dependent, okay? So you should see, but then medical reviewers will say, how can they tolerate 720 minutes of therapy every week or whatever when they're dependent? Is this really true? How are they tolerating this much, you know, if they're dependent? So it's really, it needs to be clear and paint a picture of the patient. So so we talked about why, for staffing purposes, for appropriate reimbursement, for accuracy with your care plans too, to make sure that you're putting in, they need, their transfers are dependent with a Hoyer lift of 2 people. So make sure your care plan says that instead of your care plan saying extensive assist of 1 person, because that's mismatched, right? Okay, and we talked about track the progress and decline. So who can tell me the 4 late loss ADLs? That means not that you don't have to code all ADLs, but the only ADLs that affect the reimbursement are these 4. Does anybody know one of them? Bed mobility, transfers, eating, and toileting. So those are the most important ones that you should remember. And who can tell me, well, the late loss, they're late loss because, like, as a patient declines, maybe with dementia, they have that progressive disease, these are the last things to go. So they're going to be able to feed themselves longer than they're going to be able to maybe walk, okay? So these are your late loss. That's why they call them that, and that's why those are for reimbursement purposes. So we need to remember, though, when I think of bed mobility, you know, I just think of maybe rolling side to side, right? But that's incorrect. We have to know exactly the definitions in order to code it right. So we have to know all of the little components that make up that one thing of bed mobility. Because if it's just rolling and they can do that themselves, then we're going to do independent and no support, right? But they might need help just to, they can do their upper torso and everything. They might need help just to lower their legs to the floor or just to lift their legs up. That's hands-on, physical assist, that's extensive. So we need to know, though, what all bed mobility entails. So think of it as rolling side to side, able to reach the bed rail, lifting their head up. Did you lift it up for them, or did they bending their knees or bridging, bringing their legs to the floor or bringing their legs up into bed? Can they scoot up, or did you have to scoot them up in bed? Lying to sitting, able to lift the legs, just to position a pillow in between, right, for pressure redistribution. If you had to lift their leg to put a pillow in between, then they're not independent. If they helped you and you helped, or they did it all themselves. So thinking about all those things, especially pressure redistribution when you're floating heels. Are they able to float their own heels and put that pillow underneath there, or did you have to lift their legs and put that pillow underneath? So the definition of bed mobility is how the resident moves to and from lying position, turns side to side, and positions body while in bed or alternate sleeping furniture. So if they sleep in a recliner, you're going to assess them in the recliner. If they sleep wherever it may be, that's what you're going to assess. Doesn't have to be a bed. Okay, next one, transfers. How the resident moves between surfaces, including to and from the bed, the chair, the wheelchair, standing position. Don't include the toilet, because that's under toileting, right? That's not under these transfers. One thing I think we need to remember about transfers is if they're like a slide board, did we go and help them to get the slide board, or were they able to go get it themselves, position it underneath them? What about just setting up their wheelchair in the appropriate angle, getting ready to transfer, or locking their wheelchair brakes? Anything that you do extra that they don't do on their own, that, you know, is not independent. So I think just to think about those things. Next is eating. How the resident eats and drinks regardless of skill. Don't include eating and drinking during medication tasks. This does include, though, nourishment by other means, such as tube feedings and things. So keep that in mind. Toileting is the last ADL we'll talk about. And this is how the resident uses the toilet room or commode, bedpan, or urinal, anything. So it doesn't necessarily have to be the toilet. It's how they transfer on and off the toilet, which that is really a key part. How they cleanse themselves after elimination, if they have incontinent care, if they can change their own pad or not, how they manage their ostomy or catheter, and how they adjust their clothes. Don't include if you have to empty out anything, the bedpan, the urinal, bedside commode, catheter bag, or ostomy bag. Okay, so we have two things to code per ADL, right? We code one, how the resident performed the task, and we got to remember not how they should, or, well, they were in a bad mood and they weren't willing to participate, but they usually do it this way. They say even if they're unwilling and you have to do it for them, you still code the help that you had to do, okay? So even if you know they can do it better, but they're not doing it, you still code what you had to help them do. So self-performance, how the resident performed the task, and support provided is how much help was provided by the staff. And these are the definitions. Independent, no help, or staff oversight. So that means totally independent. You did not encourage them. You didn't tell them anything about safety. You did not set up the wheelchair. You didn't go grab the transfer board. Nothing. They were totally independent. Supervision. This is hands off, but yet you're telling them verbal cues. Hey, take another bite, you know, continue to eat, all this stuff. That's supervision. If you have to cue them for the next step, usually with dementia, or even cue them for initiation. A lot of patients with dementia, they don't know how to initiate getting dressed. You have to initiate it for them. And then maybe they can do it themselves after you initiate. Okay, supervision. And then limited assist, which is non-weight bearing, but it's hands-on. So if I'm guiding somebody, which this is kind of a hard one, but like if she just needs like I think of it kind of like as a tactile cue, you know, just a touch cue. I'm going to touch her to have her to start eating, or I'm going to guide her hand up to her mouth, or but I'm not lifting anything, I'm just guiding. Or I'm getting ready to sit on the toilet, right? But I don't know where the toilet is and stuff, so you're just guiding me to the toilet so I don't miss it before I sit down. So that would be limited assistance. You've got hands on, but you're not lifting any of their weight. Okay, and then next is extensive assist. This is if you have to lift anything, regardless of how much, any part of their body, a finger, a wrist, elbow, a head. You know, we think of extensive assist as, oh, a gait belt, and I'm really, you know, lifting. Extensive is anything that you're bearing the weight of a person. So I think, you know, pretty much if you've got hands on a resident, it's extensive assist is how I feel, pretty much, except for the limited assist, but that's just guided. Total dependence is where you guys perform all of the tasks for the patient, okay? Even if they're unwilling or unable and you perform it, that's total dependence. And then an 8 is the activity did not occur. Does anybody have any questions with this self-performance and the definitions? Okay. Next is it's confusing because therapy says one thing and nursing says another thing with the assistance, okay? So the main thing you really have to know about this is extensive assistance for you guys, which is weight bearing, is therapy's mid-mod max assist. So when you hear therapy saying, oh, they're min-assisted transfer, that's not your limited assist. That's still physical weight-bearing assist, okay? So just remember, any min-mod max assist with therapy is your extensive assist. That means physical, you know, weight-bearing assistance. Total dependence is the same thing as therapy saying total assist. Independent, we're the same on. Supervision, you might hear therapy say standby assist. That's the same thing as your supervision. And then limited assist and contact guard assist. So you've heard therapy say contact guard assist. You're kind of like if you're walking, your contact guard assist, you're right there, your hands on kind of guiding, but not lifting anything. Does that make sense? Any questions on that one? Okay. And now the support provided definitions. No help or setup from the staff is a 0. Setup help only is a 1. Now that is, think about opening up their milk, getting their coffee ready, giving them their tray, handing them their clothes, positioning the wheelchair, giving them their walker even because they didn't leave it by their bedside. All that stuff is set up. And I think setup also is your cueing and encouragement and all that because you're preparing them for from preventing a fall and things with your safety cues and things. So I would code that under setup. The next one needs to be physical assist. You're actually bearing some kind of weight. So is one person physical assist equals a 2, 2 person equals a 3, and then the activity didn't occur. Questions on support provided? Okay, setup. We talked about all of these pretty much. Raising or